There we are. So yep, just as a reminder, the session will be recorded and it can be accessed on our YouTube channel for future reference or anyone who couldn't attend.
Yes. And so we are really excited tonight to have with us Dr. Anne Dixon and Dr. Gabe Tharp. Dr. Anne Dixon is a pulmonary critical care physician, the director of the Vermont Lung Center, and an NIH-funded researcher. Dr. Tharp is an anesthesiologist and NIH-funded researcher as well, who did an MD-PhD path, which is a really interesting journey to hear about. And so we're really excited to hear their paths to medicine tonight, as well as let them share their research with us.
And
So,
I was going to just say, as always, if you have any questions, please put them in the chat as we go throughout this session, and we'll have 2 Q&As, one following Dr. Dixon and Dr. Tharp's introductions and their inspiration into medicine, and then a second one after they discuss their research. So please feel free to put the chats as the session goes on, and we'll be happy to answer any questions.
Yeah. We'll give it just 1 or 2 more minutes, and then we will begin.
All right, should we get started?
Yes. Let me just pin Dr. Dixon. All right, and we'll start with Dr. Anne Dixon and her journey into medicine.
Great. Well, thank you so much. Thank you so much for inviting me to talk with you all this evening. I'm going to tell you about how I got into medicine, and that's going to be a little bit different than the path for most of you. But next slide, please. So I'm actually, as you can probably tell from the accent, I'm not from Vermont. I'm actually originally from England. And in the UK, you go to medical school straight out of high school, which is, we were discussing just before, probably a little bit too early for most people, but fortunately it worked out for me. So I went to medical school straight out of high school and spent 6 years studying medicine in the UK, did an internship in the UK, and then moved to the United States and started studying internal medicine. So internal medicine is a 3-year residency program where you rotate through general hospital medicine and all the subspecialties like cardiology, pulmonary, GI. And I did that at Johns Hopkins in Baltimore during the 1990s. A long time ago now, but that was sort of the height of the sort of HIV epidemic, so a different time. And then after spending 3 years in Baltimore, I pursued subspecialty training in pulmonary and critical care. And I'll talk a little bit more in a minute about what we do in pulmonary critical care. But that's another 3 years after residency. And I did that at the University of Washington in Seattle. And I loved academic medicine, but actually I had a baby and I was pregnant. I decided staying in academic medicine was going to be much too hard a path. So I took a job in private practice in North Carolina doing mostly outpatient medicine, totally hated it. And called back to my mentors in Seattle, and they said, "Oh, we know they're recruiting at UVM right now. You should give them a call." And so I gave them a call, and I was lucky enough to get a job on faculty here. And I started at UVM in 2001. Next slide. And so I work in pulmonary and critical care medicine. I'm actually division chief. We've got 16 pulmonary and critical care specialists, UVM Medical Center. And what do we do? Well, we have an outpatient pulmonary clinic where we take care of people with conditions like cystic fibrosis, asthma, chronic obstructive pulmonary disease, which is emphysema, chronic bronchitis, lung cancer, and some rarer diseases, scarring diseases of the lung called interstitial lung disease. And I love my outpatient pulmonary clinic. I have patients I followed there since the early 2000s, which is you establish a long-term relationship with them. We also do a lot of inpatient medicine. We have an inpatient pulmonary consult service where we consult on anybody with pulmonary problems who's an inpatient in the hospital. We have a bronchoscopy service, and in bronchoscopy, we have a video scope where we can go into the lungs through the trachea, get washings from the airway and biopsies. And we do that when we're trying to figure out if someone's got an infection or pneumonia that's not responding, or to help diagnose lung cancer. The other thing we do in pulmonary critical care is we run the medical intensive care unit. No one used to know what that was before COVID, but since COVID, people understand that in the medical ICU, we take care of critically ill patients with multi-organ failure, often with acute respiratory distress syndrome. So our group was really sort of on the front lines of the COVID pandemic. We also have a fellowship training program where we train people who are specializing in pulmonary critical care. And so we have 2 trainees a year and a 3-year training program. So we have 6 people that we train in pulmonary critical care. And next slide. And the other thing that I do, which is really sort of part of the research that I've been involved in, I will talk a bit more about that later, but I direct a research center called the Vermont Lung Center, which has been in existence actually back to 1971. And it originally started, they were very interested in silicosis. So this is something that people mining granite and marble used to get, lung disease that caused scarring and respiratory failure. So that was the origins of the Vermont Lung Center. And right now we have a big multidisciplinary research group. And we have people working on sort of oxidant signaling and how that affects the lung, stem cells in lung disease, a lot of physiology, looking at obesity and metabolism and the effects of that on lung disease, asthma, acute respiratory distress syndrome, complications of critical illness, and a big lung cancer and interventional pulmonary program. And as well as doing research ourselves, we're very much involved in training people in research. So we have undergrads working in the labs and working on a clinical research program. We have graduate students, and we have people, clinicians and postdocs who also work with us. And we try and get people excited about doing research, which is how we figure out how to treat all sorts of lung diseases. So that is what I do right now. So how did I get into the research? Well, I wish I could say that was completely straightforward, but as an undergraduate, actually, I did a project on the control of circadian rhythms, which was my first introduction. And that's how I learned which way up a pipette went, which is very helpful if you're going to plan a long-term career in research. You know, for those of you who are still undergrads, I encourage you to see if you can sort of hook up with a lab and just see if it's something you're interested in. Actually, in fellowship, I worked looking at post-bone marrow transplant-induced lung injury in mouse model at the Fred Hutchinson Cancer Research Center, which sounds a little bit obscure, but I think this got me sort of an introduction to respiratory research. As I say, I did a brief sort of U-turn when I decided this was like, I could not possibly sustain a research academic career, when I realized actually that's the only thing I wanted to do. And so when I came back on faculty here, there wasn't much there weren't many bone marrow transplants, not like at the Fred Hutchinson Cancer Research Center. So I began working on asthma clinical trials. we're part of a big national network, the American Lung Association Airways Clinical Research Centers, and we do big multi-center clinical trials in asthma and COPD. And I started doing some work actually on sinus disease with them, and obtained a grant that sort of helped me get a little bit of further training. And then sort of stumbled on this relationship between obesity and asthma, which is really what I've centered my research career around. When we did a big study and found that people with obesity who had asthma responded completely differently to the medications. And really that was sort of the impetus for me to launch what is really being sort of the main focus of my research career. So very much inspired by both sort of the clinic and some of the research that I had just started doing. And so next slide. And so one of the first sort of big independent studies that I'd done when I got interested was, you know, if obesity is making asthma worse, you know, what does weight loss do? And we have a pretty big bariatric program here at the University of Vermont Medical Center. And so I just studied patients who are going through bariatric surgery, and I included this sort of photomicrograph because it brings back old memories. This is actually a picture of adipose tissue fat under the microscope that Gabe took, either when he was still a research technician or whether it went he was now doing his sort of PhD. I can't remember exactly what, but I was working with his research mentor back at the time. And we made some important discoveries. We found that people with asthma had much more inflammatory adipose tissue. This is on the left is adipose tissue at the time of bariatric surgery. And you can see there's a lot of blue, which is cells, and red, which is sort of macrophages. And 12 months later, it's far less cellular, it's far less inflammatory. And so we found that this adipose tissue inflammation was related to airway disease. And that started a big collaboration working with physiologists, basic science, as well as clinicians. And part of being sort of a physician scientist that for me is most exciting is we work in big multidisciplinary teams, and we really sort of take the observations from the patient sort of back to the bench. And to do that requires sort of a big team effort. And next slide. And so that was a few years ago now. And so where have we gone with this? And so right now in sort of my research, I do work ranging from work on mouse models. So on the left side there's 3 pictures actually of mouse lungs. And so what we're doing at the moment, we're taking mice on a low-fat diet compared with a high-fat diet, which is LFD and HFD. And we're exposing them either to phosphate buffered saline, just saline, PBS. HDM is house dust mite. And HDM plus mito-Q is house dust mite plus a mitochondrial antioxidant. And so we're investing this mitochondrial antioxidant as a potential new treatment for asthma. And these are studies that we're doing in mice, comparing efficacy in mice. And we're actually also enrolling patients sort of at the same time. So in mice, we're trying to understand the mechanisms. In patients, we're looking to see if there's clinical efficacy. We also do studies working, collaborating with our radiologists. And what you can see here is a couple of chest CTs. So one of our theories was that people with obesity and asthma have more collapsible airways. And so if you look at sort of the top 2 pictures there, that's a patient sort of taking a deep breath in. There you go. And the next one is them breathing out. And what you can see sort of in the middle is their airways sort of in the middle disappear. And then if you look underneath at the 2 below, thank you, exactly the same is going on. And so what we found was that people with obesity who do and do not have asthma, all of them have central airway collapse. And we sort of recently published that there's sort of this big association between central airway collapse and increased weight. So that was an interesting discovery, not at all what we anticipated, but working actually with some of the engineers here and the radiologists, I think that was a significant contribution we made. And then next slide. And then the other wonderful thing about sort of being at UVM is we have a big school of nutrition. And so working with a chair of nutrition here, Jean Harvey, we did a weight loss intervention. And, people think, obesity is related to, just sort of eating too much. But a lot of people, maybe not so much in Vermont, but people live sort of in food deserts. People particularly in the inner cities, and actually some of our people in rural areas. Access to sort of good food, sort of good nutritious food is not easy. And in the inner cities, most of them actually live in what we call food swamps, not necessarily food deserts, where the only food you've got access to is really unhealthy food, and it's inexpensive. And a lot of people don't necessarily have safe places to exercise. So we recently did this lifestyle internet weight loss intervention. And we did it here at UVM, and we also work with our collaborators actually in Tucson, Arizona. And this is the hardest study I have ever done. Giving someone a pill is a much easier treatment than getting them to lose weight by eating less and exercising. But the whole idea was to see if we could do that, and we were successful. We were successful doing it here at both Vermont and in Tucson, Arizona. And as we've shown that we can do it in these two sort of geographically separate places, we're now hoping to launch a big multi-center study. So we do sort of big clinical trials. And next slide. And the other thing is we do sort of very basic physiology studies. And so this peculiar instrument that I got here is actually an adaptation of a machine that we use to measure lung function in mice. And I'm lucky enough to work with sort of some wonderful biomedical engineers, and they have jerry-rigged, there must be a fancier word for this, but they have adapted this machine so that we can, in a very sophisticated way, measure physiology in humans. And by doing this, we've really made some sort of singular contributions, showing that people with obesity and asthma have sort of a real deficit in the periphery of their airway. And when they sort of have an asthma attack, the periphery of their lung is shutting down, which differs from people with more conventional asthma. And so that's what I do in terms of research. And next slide. The other thing that doing research has gives you sort of as a physician is the opportunity to do some really sort of fun stuff. So I sit on the National Board of the American Lung Association, and one of the things we did sort of just before the COVID pandemic was we went to the National Institutes of Health and got to meet with some sort of really amazing people. So I got to meet with Anthony Fauci before anyone really knew who he was. Quite a character, I can tell you. And there I was sort of with a delegation from the American Lung Association. We went there to advocate for funding for research for lung disease. And research is really a very international thing. So I've got a chance to work with people sort of really from all over the world. And actually, this photograph here at the bottom is from a conference that I got to chair in Lucerne, Switzerland, which was one of the most fun things I've ever got to do. I got to go to Lucerne, Switzerland for a few days and chair a conference on obesity, metabolism, and lung disease, because really doing research is a very sort of multinational effort. It's also, as you can see from the top right there, it's also a very local effort. This is some of my team on the long walk, all dressed in our American Lung Association turquoise. And next slide. And other fun stuff that you get to do because of research. I was recently involved in sort of the brand new sort of national asthma guidelines, which have just been published from the NIH. And that is quite a task, let me tell you. I thought it was just telling people what they should do, but apparently it's a lot more complicated than that, I now know. So you get invited to sort of make, contributions towards clinical care. And also, you try and write and disseminate knowledge. And so this is a book we got to publish on obesity and lung disease. So the research, it's tremendous fun by itself, but it also really, as a physician scientist, it opens up sort of a whole wealth of, other opportunities, collaborating with people from around the world, and also really, getting to sort of guide major clinical endeavors, multi-center studies and changes. So I think it's the best job in the world. Next slide. Balancing research, administrative, and physician responsibilities. Well, this is always a challenge. And I think you have to be very good at compartmentalizing your time. When I'm doing my research, I focus on my research. When I'm trying to run my division or my center, you have to focus on that. And, I certainly do less clinical now, and I do less ICU than I used to. I mainly focus on taking care of patients with asthma, but getting to sort of be a physician and take care of patients really drives, the research questions. For me, it's by seeing a patient, sitting in front of you, that they can't breathe, or maybe the drugs we're getting are making them even worse. And just to really sort of be able to take that back to the bench and work with our engineers, our physiologists, and our basic science, and try and sort of figure out why that is. That's just sort of a tremendous privilege, and a tremendous responsibility as well. So I really enjoy that I get to do this, and I think the research and the clinical, they really do drive one another. Next slide. And
Okay, thank you.
Gabe.
Yeah, thank you so much, Dr. Dixon.
Of
And
course.
next, Dr. Tharp will be talking, and he will start with his inspiration into medicine as well. I'm trying to pin him. Sorry.
Already took care of it.
Thank you.
All good?
Yeah, all good.
Okay. Well, like Dr. Dixon said, I want to thank you guys for having me. This is really exciting. It sounds like a good program. So thanks for having us. My inspiration to go into medicine is probably my mom. She's has been a nurse practitioner for many years, and she was a pediatric nurse practitioner, and I grew up in the family medicine office that she worked in. And so it just always sort of seemed natural to be spending time doing that. And then I think I was in 5th grade, and I did a summer University of Denver summer program at our high school in Colorado. And I got to dissect a fetal pig with the high school biology teacher, and no one else had signed up for the class. So it was just me and him. And it was really a great experience. And I had the little pig's brain in a jar for probably 15 years on my on my shelf in my house. I think when I went away to college, my mom threw it away. But I have always just sort of been fascinated with biology, and medicine just always felt like a natural choice for me. I started out at Colorado State University in Fort Collins. I majored in biochemistry. I thought that would be a good way to enter into medicine. Everybody I knew was going into biology and memorizing taxa and learning how to classify leaves, and I thought that seemed like it wasn't going to be that helpful. So I spent a lot of time in the lab as an undergrad and kind of fell in love with running gels and doing all the sort of hyper nerdy things that you do in a lab. Learned to use the micropipette around about that time, the right direction. And then after I graduated, my course was not quite that straight into medical school. And so this is the part where you have to follow your passion. Because my wife and my girlfriend and I at the time ended up having a baby together and moving to Boston to be near her parents. And I spent several years working in a lab at Mass General Hospital, trying to get into medical school and having a really hard time. So it took me 4 years to get into medical school. I had to take my MCAT a second time because my score expired, even though it was really good. So if you're struggling in the next few years with your pathway into medicine, that's normal. And that you just have to keep working at it. And I think the year that I finally got into medical school, it was because when the interviewer asked me, "What are you going to do if we reject you this year?" And I said, "Well, you'll be interviewing me next year." And so that's the year I got in, I think. In the interim, so we had moved to Boston. I was working there. That's where I discovered MD-PhD programs. And I really fell in love with the idea because it is this really interesting bridge, as Dr. Dixon was talking about, you get to be in this really interesting position of bridging between the clinical world and the science world. And I was trying to get into those programs and having a hard time. And in the middle of that, we moved up to Burlington. I found a better job offer. And moved up here to work in a lab and ended up serendipitously working with Dr. Dixon and doing a lot of work on the adipose tissue side of her obesity and asthma study. And then I got into medical school and was still really interested in doing research. And somewhere in the third year of medical school, I started writing a grant to the NIH to fund my own MD-PhD program. So typically people get into these combined programs where you are accepted into both the MD and the PhD at the same time. And then you spend somewhere between 7 and 10 years in school getting both degrees. Since I didn't get into the program early on, I did my first 3 years of medical school and then got this NIH grant to do my PhD in my last year of medical school. And I did that on I did that on obesity and Alzheimer's disease. This idea of adipose tissue inflammation is really central in a lot of different disease processes. And so we were studying how obesity and metabolic disease might contribute to Alzheimer's disease. And what we found was that fat cells actually produce the little neurotoxic peptides, beta amyloid, that you see depositing in the brain in Alzheimer's disease and late cognitive decline. So we proved that being obese may make you prone to Alzheimer's disease simply by having more fat, making more of this neurotoxic peptide. And then I did some other studies. I think one of the things that I would just encourage people to do is follow your curiosity. One of the most fun things I did in my PhD was I took a class on bioinformatics, which is a discipline about how to take all the big data that we have out there now, all the gene sequences, all those things, and do different sort of computational work with those. And one of my professors and I pulled every gene sequence associated with Alzheimer's peptides, and then we built the most comprehensive evolutionary biology tree of Alzheimer's disease peptides, and showed that the origins of Alzheimer's disease peptides is like 650 million years ago. And that if you go back and you look at all of these old multicellular organisms like hydras, they have those peptides that could become plaques like Alzheimer's disease in their nerve tissues. So it's kind of an interesting project, and I would never have ever thought of that as interesting, except that I just kind of followed my curiosity in that class with the professor, and we published a paper on it, and it turned out to be probably one of my most favorite pieces of work that I've done. And that interest sort of has tracked with me into my training now. So after I got out of school, I started a residency in anesthesiology, and really the reason I wanted to do, Anne, I don't know if you know this story. We were walking in the hallway one day and I was saying how much I admired the surgeons for how good their hands were. And Dr. Dixon said to me, "Oh, you should see the anesthesiologists. They have the best hands in the building." So I went and spent some time with them, and I loved it. And it's super fun. And anesthesiology is really cool. I'm sorry, Lillian, do you have a slide about clinical stuff after this, or is this just?
We have just your research journey, and then we're going into balance.
Okay.
Yeah.
Okay. Well, so anesthesia is kind of a hidden specialty in the hospital. And if we do our job right, you never remember us. And so what an anesthesiologist does is they help people get through a surgery. And if you think about a surgery, it's sort of like a big controlled trauma. And so my job is to bring you in, keep you calm, get you nice and sleepy, and then hook you up to all of our tools and monitors and wires and keep you sound asleep in a drug-induced coma while you have your surgery, and then wake you up, because anybody can knock you out, but you pay us to wake you up. And there's a bunch of other pieces to that, and I'm being a little facetious, but our job is really to carry you through this trauma in the best way possible. And we do a lot of other things, but that's sort of our, we're kind of hidden from the rest of the world because you don't see us unless you come spend time with us. And I got really excited about anesthesiology when I got to spend some time with the anesthesia ventilator, which is a very specialized type of ventilator that allows you to give both anesthetic medications and control breathing very tightly. And so it just has all the bells and whistles and dials and tools you could ever want. And so it just piqued my interest. And then Dr. Bender, my residency program director, got me interested in doing some research about lung mechanics and using the anesthesia ventilator to do some specialized types of maneuvers with patients while they're asleep. And then it's really interesting because that just turned around and brought us right back to obesity. And so my research background is in obesity, and now I spend all day looking at people's lungs in the operating room. And so it was a perfect fit to come back and work with Dr. Dixon a little bit. And she's been very gracious to let me come back and do some work with her and listen to me talk about fat again. And anybody who wants my email and wants to talk about lungs and fat some more, feel free to send me some emails. And I don't have a whole lot else to say about my research journey. I think you just have to follow your curiosity. And I never would have guessed. I thought I was going to be an infectious disease specialist because I kind of came of age in the era of HIV too, and I thought that was the most important thing we could do. And it turns out I hate infectious disease. It's a terrible specialty for me. And as an anesthesiologist, I get to do procedures all day long, and everything happens in seconds. So we don't send somebody away and see them again in 3 weeks or 3 months. Everything happens right here, right now. You go to sleep now, you wake up now, you go home. But satisfying for me, I don't have to carry patients for very long. And then balancing my research and physician responsibilities. I am only 3 years out of my residency training, and I've done a lot of research in the past, but this is still a new journey for me to balance these two things. One of the most interesting things is that as a fat researcher, I've never been turned down for a sample. Whenever I say, could I have some of your fat tissue? People say you can take everything you want, take as much as you want, and then point to places they would like it taken from. And then as an anesthesiologist researcher, people say you can do whatever you want as long as I'm asleep. And so that is a very serious responsibility, because now what I have to do is balance my desire to measure everything and take samples of everything with safety. And so we spend a lot of time trying to make sure our anesthesia is safe. And then if I add something that's a little risky on top of that, we have to be very careful what we do. So I think that weighs on my mind heavily when I design a study, and I reach out to my colleagues to see if they would let their friends or family do something that I'm proposing. And from that perspective, I never do a study that I wouldn't volunteer for myself, at least right now, because it's a very, when people say you can do whatever you want while I'm asleep, that is not a license that I take lightly.
Thank you so much. We'll move on to some questions now. And so let me just pin all of us back up. And I have some questions to start. This was originally for Dr. Dixon, but for really both of you, just being in the hospital and specifically in the ICU, how have you adjusted to COVID? I know you mentioned that, Dr. Dixon.
Well, I think it's a lot easier now that they're all vaccinated. I've got to say it was sort of pretty scary at the beginning. So it's much easier. I have to say though, we've been lucky in Vermont. We haven't been as hard hit. A lot of my colleagues around the country have had just terrible time, and the worst stories. But it was certainly bad enough here, and just really traumatizing to sort of see so many people sort of getting very sick, and people who've been pretty well beforehand. And I'm really struggling now with people that don't want to get vaccinated, because it's people die, and it's just terrible to see. And when people get sick, they expose the nurses, the respiratory therapists, the doctors. And so I don't have much patience with people that won't get vaccinated.
Yeah, we spent the first few months thinking that everybody was going to kill us.
Yeah.
This is an N95 respirator, and this is how I've lived for the past year and a half whenever I'm around patients. It is unpleasant, and I didn't realize my coffee breath smelled so bad. But COVID has been really hard. Both Dr. Dixon and I are airway people. We spend all our time thinking about airways, and that's where all of these things are coming from. We built a field hospital on campus out at the Patrick Gym in anticipation of having a lot of people come, and we built these large rooms with negative pressure fans in them, so that if we did have 30 patients with COVID that were dying, that we'd be able to take care of them and intubate them around other people. Like Dr. Dixon said, this has been we dodged a lot of bullets, but it's been really scary.
The other thing, though, that I don't think people sort of realize, and we're seeing a lot of it sort of in the pulmonary clinic now, is a lot of people are having long-term complications from it. So, and young people, it's older people at high risk of dying, but I've seen sort of very young, otherwise healthy people who've just been laid low by the long-term complications. So it's really sort of changed, what we do.
Thank you for sharing. Lily, I can't see the chat. I just wanted to check.
So, yep, we actually do have a couple questions. So the first one is, do you have any advice for someone curious in the MD-PhD pathway? And what are some things people should consider when choosing between MD and an MD-PhD?
So from my perspective, you have to be committed to the idea that you are a clinician scientist. If you go into the MD-PhD, you are committing almost a decade of your life to your training, and it's hard. And your colleagues leave you behind as you go from med school to your PhD, and then when you come back, everyone seems smarter than you because they've been in medicine, they've been practicing, so you have to catch up. And then your colleagues and friends from medical school have all finished residency and are moving on in their lives, and you have to 100% commit to that as the thing you want to do. Don't do it because it sounds fun. Do it because you really, really want to do it. Um,
Yeah,
I couldn't. Oh, go ahead. Go ahead.
no, the other thing I would say is, and I don't think this is sort of really clear to people as undergraduates, but some people choose to do their PhDs after they've done their clinical training. I mean, that's not necessarily easy either, and it's still a huge commitment. So if you're really committed to doing research, and there's not that many MD PhD slots around the country, so people can sort of find their own way as well. I mean, the way that Gabe did his MD PhD was very much a self-directed way that he was able to do it. So there are different ways there than just the classic MD PhD program that you sort of apply to.
Yeah, and when I struggled to get into the combined degree programs, um, people kept saying, "Well, why don't you just go do a PhD?" And because you're clearly passionate about the research part, and it just wasn't the right fit for me to only work in the lab. That sort of motivation from having patients and seeing patients every day and sort of putting a reality to the disease processes was what I wanted to have. Um, but if you can't get into those programs, or because they're hard to get into, and you really are dedicated to it, then become a physician and you can do more training afterwards. You can be a square, you can be a rectangle, but not a square. But I don't know how to make the right analogy here. But if you are struggling to get into the combined program, get into medical school, because once you're in, the doors open up in different ways.
Wow. Yeah, I think that's seems like great advice, and very well said. We have another question. This is for either Dr. Dixon or Dr. Tharp. You both can speak about it as well. It says, do you feel like you have to prioritize being a physician or being a scientist? Or do you find being in both arenas results in a more synergistic effect?
Yes. Well, on different days, you might need to prioritize being a clinician. So right, that there's a major pandemic going on. It's all hands on deck. You've got to be a clinician. But I would say, usually it's sort of synergistic, and I tell people I almost feel like I use different sides of my brain when I'm working on my research and when I'm working in clinic, and they're very complementary. I mean, taking care of patients is really sort of what drives my research. But doing the research also gives me the energy to sort of, go back and take care of the patients. So I derive energy for doing both, each from the other. And I think, people who do, research and are clinicians probably people who get bored very easily. If I had to do the same thing all day, every day, I think I would go, I would really struggle with that. I love the variety of what I do.
Yeah, I agree. I think they are synergistic to each other. I wouldn't be happy doing one or the other.
Right.
Okay, great. And then another question is for Dr. Dixon, and it says, do you think your research will grow to incorporate COVID?
Oh, great question. Oh, yes, it has. I did not touch on that. So obesity is a major risk factor for COVID, and that's certainly come out of the pandemic. And in fact, we looked at the data in our ICU here at UVM Medical Center, and so being obese is a major risk factor for getting admitted to the ICU and requiring ventilatory support. And so I touched on the studies that we're doing in mice, looking at the mitochondrial antioxidant. So we've discovered that the mitochondria in the airway epithelium are dysfunctional in people with obesity. And actually, airway epithelial mitochondria involved in host defense against viruses. And so we have started working with non-SARS-CoV-2 coronavirus, but we're just getting into the BSL-3 facility to do this with SARS-CoV-2, to infect airway epithelial cells from lean and obese people with coronavirus and see the effect on inflammation. And our hypothesis and what we've seen with other viruses is that the obesity increases inflammatory responses to viral infection through this mitochondrial dysfunction. And so we're also going to get, there's a mouse which bears the ACE2 receptor that you can buy, and we're going to, in fact, we're going to make some of those obese and keep some of them lean, and we're going to infect them with SARS-CoV-2. So we have a pilot grant from the medical center to do this work, and we've got a grant going to the American Lung Association. Actually, June 3rd is the deadline for that one. So yes, we're definitely working on that one. We're pretty excited about that.
Wow,
Great
yeah.
question.
I had a question actually on, just for both of you to speak on the process of applying for grants and what that's really like, and how easy and or really tough it can be to get funding.
It's a mess. It's a lot of work.
It's a lot of work, but what I tell everybody is, particularly if you're getting funding from the government, this is taxpayer money. So it's really important to justify the importance of your work. And so when we put in grants, on average, sort of 10 to 20% of those grants will be funded. And so you've got an 80 to 90% chance of rejections. So what I tell people who are interested in doing research is you got to learn to have a thick skin, and you got to learn to embrace rejection, because we all get rejected more often than we get our grants accepted. But hopefully when you get a grant rejected, that it goes to a formal review process, you get feedback. And sometimes actually that feedback is very helpful, and it makes it sort of into a better process. So the grant process is not easy, but I think it being not easy sort of makes the science that we do better. But it can be very painful when you get those comments back on the ground and they say, well, this was wrong, this was wrong, this was wrong. It's very hard to sort of back to the drawing board. So we do a lot of going back to the drawing board.
One of the things I love about it is it's really creative.
Yeah.
It's one of the creative. So medicine itself is not a real creative job. There can be creative things, but writing grants and coming up with new ideas and studies is really, really like an artistic and creative endeavor. And then I put a constraint on myself in my PhD that I don't work in anything but humans or cells anymore. And so that makes it really hard, but really there you have to try it. You have to work really hard to find the right way to get samples or do your experiments. And so I really like the challenge in that. And so even when the reviewers hate it or whatever, I still think I like the creative process of coming up with ways to get an answer that don't involve mice.
And then,
Okay,
oh, I'm sorry.
No, continue. No, keep going.
You're absolutely right. When we do an experiment in mice, you can do, you do ethical things, but you can get, you can get their organs. Whereas when you do stuff in humans, you've really got to be very, very creative. And some of the time, you use, almost natural experiments, like the study I did of bariatric surgery. I mean, they weren't going through bariatric surgery to sort of see if the effect that it could have on the asthma, but that was a convenient model for me to investigate their asthma. So you've got to get creative and think, how can I address the question? And I think that's one of the things about being sort of a physician scientist is you have to be very creative. You can't necessarily do the experiment you want to do, but you've got to figure out what's the experiment that's possible to do that will answer your question.
And all this happened to me in my graduate work. There are all kinds of things that people show in animals that don't translate out to people. there's this huge sets of data on diabetes in mice, and it doesn't translate to humans at all. And so at some point, I decided that I was only interested in human physiology, and that has been a nice line in the sand, a hard one to work with, but it allows, it sort of gives constraints to the way I would try and work and develop a study.
Just wondering, Dr. Tharp, if you were talking about samples you take during an anesthesia procedure, and I was just wondering what type of sample you would be taking for your research.
So the research that we're doing in the operating rooms is a lot about how the lungs expand and contract, and sort of the physical parameters behind that. So if you imagine them as a balloon or a spring or something, we measure lots of different things about that. And then everybody has an IV, so I have access to blood samples. People have an endotracheal tube, which is a tube that goes in your mouth and down into your throat, and that gives me free access to the lungs. So I do a lot of intraoperative bronchoscopy now, like Dr. Dixon mentioned earlier. I fish this fiber optic scope down into the lungs, and I can put it down in different places and take small samples. So I can take small washings of the lungs or things like that and collect cells. And then wherever the surgeons are working, generally I can get a sample from them. So, you know, if I was really interested in brain cancer, I would work very heavily with the neurosurgeons to get samples. Right now, everything I do is sort of focused on obesity and lung mechanics. So the studies we're working on now, I'm trying to get set up to take adipose tissue, blood, and then washings from the lungs. And that's sort of what I have going on right now in sampling. But you can imagine, you can get just about anything, and people are okay with it once they're asleep. So as long as it's safe, we can make a case to do that.
Wow, great. And then would both Dr. Dixon and Dr. Tharp, maybe you can speak on this. Would you say that most physicians in academics do research, or is it a lot fewer who do, or do you find that a lot of physicians are interested in and participate in research?
I would say most probably try research sort of somewhere along the line with their training, but nearly all in academic medicine teach, and only a few perhaps do research. But there's sort of different types of research that you can do. I mean, I think what Gabe and I do sort of is sort of very classic, sort of, you know, bench to bed research. You know, there's also a lot of interest sort of in sort of hospital systems and quality research, which is another sort of subspecialty research that people do. But I would say the majority of sort of clinicians working in academic medical center do not necessarily do research, though some of them sort of may collaborate, and nearly everyone has some level of interest.
Mm-hmm. And then I guess I also have a more like lighthearted question for the two of you as well. But maybe if you wanted to just speak on like your favorite part of research and then your favorite part of being a clinician, just to kind of like what drew you to do both and why you still enjoy doing both.
My favorite part of research is sort of looking at data and figuring stuff out and thinking, no one else has really thought about this before. Or I mean, it's a voyage of discovery, right? And I get to think for a living, and it sounds silly, but there are so few jobs where you really get to think creatively for a living, and I get paid to do that, which is just sort of a tremendous privilege. So that's what I like most sort of about the research. What about you, Gabe?
Same. I think the discovery is really the fun part, and I'm a sucker for data. I like lots and lots of data. I like to look at graphs.
Yeah, you really do.
I'm a real nerd. I like graphs. I like to look at graphs. My secret, let me tell you my secret for designing a research study. I draw the graph I want to see, and then I work backwards from the graph. But I'm not even kidding. I don't have one up right now on my whiteboard. This is my most important research tool, is my whiteboard. And I draw the graph that I want to see, the data. You know, I draw what I think is what I'm gonna see, and then I try and design a study to get the graph.
But I'll let you into a secret. Half the time, more than half of the time, the graph turns out the complete opposite way from the way that we thought it was going to do. But you know what? That's really exciting as well, because it tells you something. And
That's
it's
even more
looking at the
exciting.
data and trying to figure out, what does this mean? And it's so exciting.
Thank you so much for that. We can move on to the little case study aspect we have, and then we'll have a little bit more time for questions at the end. And so we'll move on to that right now.
Okay, cool. So I brought a couple of slides about a technique we use in the operating room called electroencephalography, or EEG, and it is a method of monitoring the brain waves. And I tagged this slide that says, "How do you know when I'm asleep?" And I get asked that question all day, every day. How will you know when I'm asleep? How will you know that I'm still asleep? How will you know that I'm not waking up in the middle of the procedure? And so one of the best tools for that now is using this modified EEG. So you want to, next slide. So I'm sorry, I apologize. I put a little thing over the trade name there. I'm not endorsing this brand. But that little set of stickers down on the bottom there, if you imagine them going over your forehead, and then these two on the sides sticking out here over on your temples, I put one of those on you before you go off to sleep, and you might, and then the electrical activity of your brain can be read in those electrodes. So I can get an output from the frontal part of your brain on those electrodes. And if you look at this slide, there's one here that shows this picture of the brain, and it says conscious above it. And you can see this nearly flat line with a lot of high frequency squiggles on it. And that's what most of our brains look like right now if I were to put that on all of us. Some of you may be asleep, but that's okay. And then as I give you hypnotic medications, your brain waves start to change as you start to fall asleep. And this is different than regular sleep. This is a coma type sleep. And you can see that they made this little, cartoon here has this sort of circular piece between the cortex and the thalamus, which is a part of the brainstem. And when you start to give these hypnotic medications, you stop having all this high frequency activity. The neurons stop firing independently and they start firing together. And when they all start firing together, they slow down and you no longer have consciousness. So your brain, the individual firings really fast is your brain working and the neurons working by themselves. And as I give you hypnotic medications, they slow down and they sync up. And you can see that slow underlying wave on the unconscious phase there. And if you flip to the next slide, we can do some fun things. And I see the question about dreaming under anesthesia, and I'll get to that in a second. If you look at this slide, you can see this thing that says unprocessed waveform. And that's what we see on the screen when we use those electrodes. And then if we use a little bit of, the computer does some math to separate out different pieces of those waveforms. And then you can take those separated waveforms and plot them out. And the amount of each different type of waveform tells me about what's happening in your brain. And this picture on the far right is a derivative of all those waveforms, but it shows me that this person has a lot of waves in this sort of 10 to 15 hertz range, and a fair amount down in this sort of near the 0 range. And that's a very classic picture of someone as their brain is falling asleep. And if you go to the next slide, you can see this picture at the top is a plot of that image over time. Each little slice, each little vertical slice is about 30 seconds. So if you look at that picture on the far left, you see sort of a lot of red down below the number 10 and a little bit of yellow above that. And as you move across, it suddenly sort of gets compressed down to close to 0. And then as you get to the number 90 minutes there, all of it sort of dissipates, and there's a lot of sort of yellow and blue in there. And what's happening is on the far left, the patient has one anesthetic medication on board. And then you can see that they started another drug called nitrous oxide, and that changed the way the brain was functioning, the combination of the two drugs. And then the drugs are turned off, and the patient's brain starts to come out of anesthesia and wake up. So I can watch these while you're sleeping, and I can tell you how sleepy your brain is. And generally, if your brain looks like this by the waveforms, you don't make any memories and you don't have any dreams. People will tell me they dream under anesthesia. Oftentimes what they are dreaming is they have a dream in the 5 minutes right as they're waking up. So they'll have sort of a really short, compressed amount of dreaming as they're waking up, often like people do as you might lucid dream right before you wake up. But when people are deep under anesthesia, generally you don't make any dreams. You are completely inert. And then each of the drugs does something a little different. Different hypnotic medications give different types of brain waves. And so you can see here on the very bottom, there's the characteristic brainwave spectra of propofol, of one of the inhaled agents, sevoflurane, of another drug called ketamine that's a hypnotic agent with a very different type of action, and you can see how different that brainwave looks. And then on the far right, you have one called dexmedetomidine, and that brain looks like it doesn't work at all. What's amazing is that patient on dexmedetomidine, if you reach out and poke them on the shoulder, they will wake up and talk to you and then fall back asleep. So it's really, we can really tightly control how awake and how asleep you are using your brain waves. And I can do anesthesia for awake brain surgery using dexmedetomidine. It's wild.
Dr. Tharp, could you describe one of those surgeries? It just sounds, and for both you and Dr. Dixon, it's just a time, if you have any last interesting cases or clinical experience or research moments that you wanted to share, we could share this before the final Q&A.
Sure. So if you have really bad Parkinson's disease or really bad epilepsy, we might do awake brain surgery on you. If you have really bad Parkinson's disease, we would put electrodes through your skull down into parts of your brainstem or near your brainstem and stimulate those areas where the nerves are dying to help prevent the motor problems of Parkinson's disease. And to do that safely, you have to be able to talk to the patient while they're having the electrodes placed in their brain. So your patient has an enormous metal frame pinned to their head, drapes up and away from them, and an enormous metal frame around them, and they're sitting in an operating chair staring at you. And then you let the surgeons open their skull and begin working. And when the surgeons are ready, you wake them up a little bit by poking at them, and they will wake up and talk to you. And you ask them to move their arms or move their hands while they're placing the electrodes. And for an epilepsy surgery, they do the same thing. They try and take out as much of the epileptic part of the brain without harming the motor section. So they would slowly take out pieces and make sure the person could still move their hand or their foot. That is one of the most interesting clinical things I've ever done, to do awake brain surgery on people.
My interesting research and clinical experience that I would just going to relate, sort of related to the same. So one of the things that you most hate as a physician is to be on a plane and the call goes out, is there a physician on the plane? And so I was flying to this meeting in Europe, and you're about 3 hours into the plane over the Atlantic, which is another bad thing as well, because there's no airport to land in. And the call goes out, is there a physician on the plane? And you're like, I'll let them call again. Maybe they're not serious. And then the call goes out again. Is there a physician on the plane? So this was a plane that I was on. Actually, I was going from Montreal to Zurich. And it did appear that I was the only physician on the plane. And there was another passenger there who was pretty sick. His heart rate was going about 180. His blood pressure was not great. Now, all planes sort of carry sort of emergency kits. And so, I had to resuscitate this person. I was sort of the only person there. As the attending physician, I don't usually have to put the IVs in or sort of push the meds, but we did all of this and sort of pushed all the fluid that we had. And his blood pressure was not great. And so then the cabin crew said, the pilot says, do you want us to land the plane? And I got to tell you, as a physician, I make a lot of life and death decisions, but I've never had to tell anyone to land a plane. And that was the most intimidating decision I've ever made in my life. But anyway, so they landed this, big plane, and we landed in Iceland. And the sort of paramedics come on board, and so there am I on a plane from French-speaking Montreal going to Zurich. The patient actually is from Pakistan, and the paramedics are from Iceland. They get on the plane. Everyone is talking to me in English. It was just sort of very humiliating. I mean, I sort of knew how to resuscitate the patient, but I was stuck in one language. But anyway, that was probably one of the most sort of interesting. It was research, because I was traveling to a research meeting, and sort of clinical experiences I've had. I don't know, has that ever happened to you, Gabe? Have you ever got that call? Is there a physician on the plane? I hate it.
I was a medical student at the time that happened, and they didn't really need anybody without any skills.
Yeah. So that was a memorable research meeting.
Yeah, I think that's one of those things that everyone kind of dreads, to be called into work while you're trying to fly somewhere else.
Right.
Wow, that's an unbelievable story.
It was not
Definitely
pleasant.
one that you think,
So now,
sounds
as
like
a caveat, as an anesthesiologist, you do put in all your own IVs and push all of your own drugs. So it's a slightly different practice, but
You
it
weren't
might
there.
help you. It might help you on the airplane.
Next time I'm flying with you.
Fine.
Well, I had another question to start off, just our last Q&A. So if anyone has any final questions, they can put them in the chat right now. But I was just wondering how Dr. Tharp mentioned that you, Dr. Dixon, said that anesthesiologists have the best hands. And I just wanted to know what you meant by that.
I was being nice. Well, no. It's sort of interesting. Everyone thinks, surgeons have to have very great motor skills, and they do sort of procedures. But I think there are a lot of other medical subspecialties that do. And I don't want to give Gabe too much praise, but anesthesia is at least as important as the surgery. And what those people are sort of doing at the head of the bed, while the surgeons are doing their bit, is pretty cool. So when he was praising the surgeons, I was sort of praising the doctors that I sort of admire too.
Thank you.
And I had a question for you, or I guess more of like a clarifying question for you, Dr. Tharp. So Jillian and I were both neuroscience majors, and we definitely learned a lot about like brainwaves during sleep in our 4 years. And so I just wanted to clarify. So we learned about like when you're in your deepest sleep, the type of brainwaves associated with that, and they're usually like a lower frequency than you would see in an awake state, or even if like in your dreaming state. So those are the same types that you see when someone is under anesthesia. Those or are they the same, or are they just slightly similar in the fact that they're like a lower frequency?
they're close. You get to a much lower frequency in anesthetic sleep. So I don't believe, and you may have to correct me on this, but I don't believe that you get down into a really deep delta wave during normal sleep. Maybe briefly, but that lowest frequency wave where all the neurons are synced up is a pattern between the thalamus and the cortex, and it is not a natural rhythm that happens in sleep. It's sort of a dissociated, we think it's probably an underlying rhythm that is sort of conserved that we just unmask. If you're really interested in this, there's a great Radiolab podcast about anesthesia and the brainwave monitors from two folks in Boston who sort of invented a lot of the techniques we use. So it's really, I would highly recommend that. But chemical sleep is much different than normal sleep.
Thank you.
Well, yeah, thank you.
I had another question.
That does kind of make sense.
Yeah, for Dr. Tharp, you were saying how you had a tough time getting, or just a long journey getting into medical school. And I just wanted to know if you had any doubts or what really helped you push through to really pursue that path. Because I know for a lot of students, it's a really daunting and challenging thing ahead of them.
I have some sort of, I don't know how to answer that well. One of the things I would say is that I just don't take rejection well, and not in the sense that I can't handle it. It's just that when I'm told no, I tend to say, oh yeah, watch this. And that's just the personality trait I have to own. But the other half of it was that I had an infant son, and I didn't have a good idea of a job. I was struggling to find a job. It took me a long time to get a job in Boston. And then once I sort of got myself in the door, I said, okay, now I still have this track that I want to go for. And I think for me, the motivation was having a little kid that I had to take care of and provide for. And so that, that sort of, the reality was that gave me the motivation to keep going. I think had I not had a kid at the time, I might have not pursued it.
I don't know. I think you would have pursued it, knowing you.
Thank you.
Well, but I think that's sort of so important. It's not just sort of the hurdle of sort of getting into medical school, but through medical school and completing training and sort of if you want to sort of do research, the rejection sort of the grants. I sometimes tell people that in this job it's the most successful people are the last people standing. It's not just the hurdle. There are so many hurdles.
The hurdles never end.
Right. And I think sort of the most important sort of life skill for a career in medicine is just picking yourself up and dusting yourself off and just sort of keeping going, because we all get rejected all the time.
Yeah, I had sort of a similar question for you, Dr. Dixon, and wondering if you had like a defining moment that solidified your desire to go into medicine, especially because you were going straight from high school, which, a lot of people discover, in their undergraduate studies, that's something that they want to do, like that's typical for here in America. So I was wondering if you had like a moment that really made you want to pursue going straight into it.
Well, I really enjoyed science, and I really enjoyed sort of biology, when I was in high school, and I'm neither of my parents have sort of gone to college, so I wasn't sort of that sure of sort of what careers were out there, and medicine was sort of is one of those careers that everybody sort of knows about, because everybody sort of knows a doctor, and so for someone that loved science and sort of loved biology, you know, that was the way that I could see forward of doing it and going to medical school. And so that's the real reason I went to medical school. And I was right.
Well, thank you. That's great to hear. So again, feel free to add any more questions into the chat.
Perfect. We'll give it just a minute. And then just for everyone, for our next session, just to let people know, we want to first just thank you so much, Dr. Dixon and Dr. Tharp, for being here. This was such an incredible session. I've really, really enjoyed talking to both of you and getting to know both of you and your paths. It's been incredible. And our next session will be June 24th with Jeremiah Dickerson, who's a child and adolescent psychologist, as well as Molly Bumpus, who is a speech language pathologist and clinical associate professor in the Department of Communication Sciences and Disorders. And so that will be a really interesting session as well next month. But yeah, we'll stay on for any final questions. But thank you everyone for being here tonight. We really appreciated it.
Thank you
this will
so
be
much.
recorded and uploaded to our YouTube channel.
Yes, so feel free to refer back to this or share it with anyone who you think might be interested. And again, thank you, Dr. Tharp. Thank you, Dr. Dixon. This has been super, super interesting. I've learned so much, and it was really great talking to you both.
Yeah.
Well, thank you, Lily. Thank you, Jillian, for organizing it. This was a lot of fun. Thank you.
I'm glad. Thank you. Well, it's not seeming like we're getting any more questions, so I think we are good to end it. Thank you again, everyone, and enjoy the rest of your night. Enjoy your weekend.
Thank you, everybody. Take care.
Thank you.
Thank you so much.
Thank you, Kara.